with Dr. Agarwal for the Cancer Prevention and Control Program, and I appreciate the opportunity to speak with everyone today. I wanted to start out with just a one announcement that comes from our work in terms of writing the Cancer Center Support Grant, and it has two layers of encouragement. One is to encourage everyone to use the Cancer Center shared resource facilities to support their research. Cancer Center members get a discounted or subsidized rate for their work. But alongside with that, to encourage everyone who does use those shared resources to cite them in your publications and make sure that you proceed to the point where you get a PMCID number that acknowledges the fact that that research that you've conducted was supported by the federal government. And then that allows us at the shared resource facilities to take credit for that when we write up our Cancer Center Support Grant. And it's a vital part of how we're evaluated in terms of the science that we help support and produce. So if anyone has any questions about that, please do not hesitate to contact us or my colleague Marcelo and Elizabeth Meyer with Population Health Shared Resource can also help sort out some of those kinds of issues. I'm going to go ahead and transition. As you guys know, I took the liberty of allocating some time to try and present my own research within the seminar series as a way of kind of helping introduce you to me and the work that I do, in addition to serving as the co-leader here with Raj. It's been an awkward year to try to get to know everyone, but I hopefully will have a vaccine soon and be able to meet in person and to for me, the opportunity to get to know more of you. I've had a great time writing about your science over the past 6 months in the Cancer Center Support Grant, so it'll nice to finally be able to put a face to some of the words and some of your writing and things that Raj and I have been going over for the last 6 to 8 months or so. But I'm going to go ahead and transition to sharing some of my research. And I titled this presentation, Expanding Beyond Prevention, Behavioral Lung Cancer Prevention Control Cautiously Considers Early Detection and Survivorship. And the reason I did that is because for so long, the landscape of lung cancer prevention control has been prevention. And in many ways, we focused so much on tobacco because we've had so few other options. We really didn't have an environment where we had an early detection program that improved outcomes or reduced mortality. And survivorship wasn't that big of a deal, unfortunately, because of the devastating aggressive nature of lung cancer, the late detection with survival rates hovering around 13% for many decades. But that has all started to change. And so the whole field of behavioral lung cancer prevention control is kind of cautiously dipping its toes into the concepts of early detection and survivorship. And I'll try to introduce some of those concepts and talk about them today. So until January, my outlook on the world was mostly through a window out to Kentucky, which obviously is quite a bit different than Colorado. And I'll be able to share some of the epidemiology and why lung cancer was such a predominant focus of our work in Kentucky. So what many people know about Kentucky is the Appalachian Mountains, Kentucky Derby. For those Denver Nuggets fans, here is a gentleman that first played in Lexington before he habited the court downtown, Jamal Murray. And then this Raj's favorite, this brown liquid here at the bottom that can go for several $1,000s a bottle. That's Pappy Van Winkle. I don't know if any of you watched 60, or I think it was Sunday Morning, did a special on Pappy Van Winkle. It's one of the more expensive bourbons. But another thing about Kentucky is that tobacco was very much a part of the culture of Kentucky, from growing, processing. The companies used to be located in Kentucky. Many of them have left and are now habit North Carolina almost entirely. But it's also part of the culture in terms of very high rates of adult smoking and tobacco use that really perfuses through the entire society. And just thought I'd talk a little bit about the burden. If you look at the incidence of lung cancer, you can see Colorado actually has a much lower rate. Kentucky is not so fortunate. There's no other state that's in the triple digits in terms of this this metric that is reported by the American Cancer Society, and it's 2.5 times greater than the burden in Colorado, and the mortality statistics are highly similar. That in Colorado, once again, it's twice as high in Kentucky, and then obviously that's very highly correlated and attributable, although there is some interesting differences with the US rate dipping below 14 while Colorado still hovers higher than that. But the rate in Kentucky is still almost 1/4 of all adults continue to use tobacco. Only recently in the past 2 years have Kentucky been able to dip down as not the #1 tobacco use state, and that has tipped over to West Virginia. Thankful to them for this distinction. Unfortunately, it is largely attributable, in my opinion, to the fact that West Virginia eliminated their state tobacco control program during budget cuts and no longer make any real legitimate efforts to reduce the burden of tobacco in the state. This is another recent depiction of the devastating toll that you can see that hovers over Appalachian, Kentucky, and some of the regions here where just an absolute devastating rate of lung cancer mortality. And it's really, you can look at the numbers, but these are obviously real people and real families. There's almost no one in Kentucky that doesn't have a firsthand experience with a family member who's died of lung cancer. So that experience is something that's just part of the culture of Kentucky, particularly in Eastern Kentucky. And this is using some of the Kentucky Cancer Registry data. You can just see how that distribution of lung cancer incidence is not distributed equally. You can see here, this is the Appalachian regions that we work in heavily with regard to the lung cancer burden, but also some areas of Western Kentucky. These are also coal mining areas that are a little bit less common in Western Kentucky, but very common in Eastern Kentucky. And then also some areas up here along the Ohio River bordering on Ohio and over a little bit over here into West Virginia. But some of these communities, not in the 1990s still, we're reporting adult smoking rates that north of 60, 70, and possibly even 80%. That's how you get a 25% tobacco use rate across the state when some areas are obviously much lower. My lab has looked at behavioral issues across the spectrum of lung cancer prevention control. We've worked on prevention or risk reduction efforts, trying to bring some novel approaches to using technology and motivational interviewing into the dental healthcare setting, as well as obstetrics in terms of our prevention efforts. Much of what we've worked on is in early detection, whether it's helping support informed and shared decision making, but we also have a footprint into the implementation steps of helping mostly rural, but some urban and other areas implement lung cancer screening in a high quality manner. Because it's so new, it doesn't come firsthand, and many of the folks that are running lung cancer screening programs are sort of new to the game. We've also worked on some things around diagnosis and treatment decision-making at the time of diagnosis, as well as tobacco treatment efforts following immediate diagnosis. In the survivorship space, we have a lung cancer survivorship program that we've worked on, and I'll share a little bit with you today about that if we get enough time. And then one of the more recent additions in the past few years is really looking at lung cancer stigma and how it impacts the entire lung cancer prevention and control spectrum. But today, I'm going to spend most of my time talking about some of the early detection efforts, as well as hopefully have some time just to highlight a few things about our survivorship care initiatives. So one of the first things I'll talk about is our work on Lucas Choices, which is an informed decision support tool that we've developed with more of a population-based framework. I'll also talk about the Kentucky Lung Cancer Screening Roadshow as one of our community engaged efforts to spread the word about lung cancer screening options. Might have a chance to talk about Project ACTS, which is a fundamental program that targets individuals or targets programs, once again, with lung cancer screening to emphasize adherence based on some of the data that we have. And then also working with our QUILS, which is a quality implementation metric for lung cancer screening. And then our precision lung cancer survivorship program from the Kentucky Leads. I hope to have an opportunity to address a little bit about each one of those. And I probably won't get to the point where talking about our lung cancer stigma work or our QUIT advisor work on lung cancer prevention, risk reduction, and dental healthcare settings. So transitioning into the lung cancer screening environment, we have this opportunity for this fantastic paradigm shift that is the first time that we've been able to do something different, unique since 1964's Surgeon General report, where we're really adding a new layer onto tobacco treatment with the data that came out in 2011. From the NLST, as well as data from this year's Nelson trial, which is a Dutch-Belgian trial that also showed a mortality reduction associated with lung cancer screening that has been translated into policy with the Preventive Services Task Force, as well as the Centers for Medicare and Medicaid Services adopting lung cancer screening as a covered service. And so the next challenge is actually implementation and taking this new technology and putting it into communities where we can truly leverage the benefits of lung cancer screening and see hopefully a continued dramatic change in the curve of lung cancer mortality. In many ways, I think of lung cancer screening as sort of a live action clinical and translational science activity that we have reached a phase where we're actually in the dissemination, we are in the field, we're figuring out how to take this vital data that came from very strong efficacy phase 3 clinical trials and making sure our communities have access to this great new tool. And so what am I talking about? I'm talking about implementation science, of course, and Colorado has a very unique footprint with some very talented individuals who have been pioneers in the implementation science space that helps us understand the barriers and facilitators in the context of translating this data into community settings. I think of low-dose CT and lung cancer screening as very similar to the new 2020 Corvette. Fantastic, beautiful machine built and designed in Bowling Green, Kentucky, as just a really marvel of engineering. And that's similar to what we have with the low-dose CT. We have this beautiful new machine that's ready and raring to go. We have the incredible amount of data that is the fuel to power this machine in our communities. We have very strong efficacy data that shows that just what a wonderful tool this could be in terms of improving health outcomes. We've developed programs around lung cancer screening. We have the manager and the pit crew in terms of our medical directors and our navigators. The struggle here is that these folks are new to this game as well. They've not driven this car, they've not managed this vehicle before, so we have a ways to go with that. Primary care is our ignition switch. Based on how lung cancer screening is structured, it really starts with primary care in terms of conducting shared decision-making and launching this process forward to engage people in the lung cancer screening opportunity. The individual patient, I see them as the driver. They need to be at the center of this process. They are the individual who is actually in the lead. The challenge is that is similar to the people who are leading our lung cancer screening programs, that these folks are equally inexperienced. We've not screened this community of individuals before. As a matter of fact, it's kind of worse than that. And because so many of them have a smoking history, that we've not treated them that compassionately or empathically in the healthcare setting. And so they come to us with a bit of an edge to them, and rightly so. And so there's ways we need to break that down in order to help them navigate through the lung cancer screening process. And finally, the whole lung cancer screening experience is kind of a bumpy new road course. It's not the wonderful oval that we see on TV, but rather a really complicated course and trajectory that we need to help folks navigate. So basically, we've got a beautiful tool that no one knows how to do this use this tool most effectively, but it's really going to take a team of us coming together and putting the patient or the individual at the center of the process, which we think is really going to give us the best opportunity to leverage this situation. So we have the data. We have this data has been translated into guidelines from the U.S. Preventive Service Task Force, as well as other entities that have provided a platform and encouragement for implementation. And one of the cherry on top has been the funding. Due to the Affordable Care Act, as well as the decisions of the Centers for Medicare and Medicaid Services, the vast majority of individuals have access to lung cancer screening for no charge, as long as they meet the eligibility criteria. And really, the next challenge is taking this into the community and implementing it in hopefully the high quality way, so we can see similar results that have been achieved in the NLST and the Nelson trial. But there's already found some pretty significant glitches to that translation. So if you don't know this already, I'm originally from Iowa. I'm in love with Iowa. Iowa's who I am. And so you'll get many references to Iowa. And I'm not sure if there are any musicians out there, but this is a Iowa reference to the Music Man. But we've got troubles right here in the low-dose CT environment. This is just a sampling of the papers that have been published showing challenges, whether it's inappropriate uptake of lung cancer screening, we're screening the wrong people, we're causing more harms, we're not following the protocol, just a host of different challenges that are facing the implementation of lung cancer screening. And why do I say cautiously considers early detection, and what does the implementation data tell us so far? So this data is from the American Cancer Society, as well as federal sources. It was collected in 2010, prior to having any lung cancer screening policy endorsement or data for that matter to support the fact that low-dose CTs could actually reduce mortality. And you can see that just around 2, 3, 4, 5% maybe of individuals had reported that they had been screened, or documentation of screening. We had the data reported in 2011. At the end of 2013, we have policy, and the first 2015 is the first full year of essentially of coverage for both Medicare and Medicaid services, as well as USPSTF. And so we see this whopping increase of uptake in lung cancer screening, doubling the effect. And of course, I'm being sarcastic here, because that's why it's cautiously. There really hasn't been this warm embrace of lung cancer screening and to implement it in a variety of settings among eligible individuals. Technically, the National Health and Review Survey showed a statistically significant increase, but you could hardly argue that was a population health valuable increase in terms of uptake. The American Cancer Society data showed that there was no statistically significant increase, even with the introduction of data and policy. So we have translation policies. And of course, the fundamental explanation for this difficulty is that translation takes time. But also there was a fairly heavy field of dreams fallacy. Prior to the launch of the supported policy, after the data, but before the policy, there were articles in the literature saying we don't have enough low-dose CT scanners to meet all the demand for lung cancer screening, and because we're going to have 12 million individuals who are suddenly one day going to be eligible. And so they were falling into this fallacy of if you build it, they will come. But this fundamentally fails to understand who we're serving and the community that we need to engage, and we've not done that well. In terms of awareness, our community level awareness is still at virtually zero. Our organizations are gaining some experience and expertise in lung cancer screening. They're growing. We have advocacy organizations who are pushing this information forward into our communities. Healthcare systems are starting to recognize this. Their lung cancer screening programs are propping up everywhere in all kinds of different settings. Our clinicians, primarily our primary care groups, need to be aware of lung cancer screening, because remember, they're the ignition switch to get this process going. And virtually among screening eligible individuals, we're still at essentially zero in terms of population awareness of screening as an opportunity for this group. Maybe 5 to 10% of individuals who are eligible have a sense that a lung cancer screening is an option for them. And part of this is because of failed awareness approaches. Our awareness approaches have not been very person-centered. They are based on fear appeals, essentially sending the message of get screened or die. That's not really an appealing message to this group, and we have to think about how to do this differently. They also use stigma appeals or just plain out rational appeals, and that have not been very effective in terms of turning eligible individuals into participants. And that part of this is due to the fact that the entire environment is filled with clinicians who are not entirely screening oriented people. They do not understand the complexities of choices of individuals to be screened on a population health basis. And so there's a lot of training that still needs to occur in order to really leverage this new tool and to reduce lung cancer mortality in a way that is partnering with our communities and individuals at risk. So not all of it's doom and gloom, though. There are some pockets of success that where lung cancer screening is being implemented more broadly. No one is happy with the overall volume, but nonetheless, some areas are leveraging it better than others. Particularly in the Northeast, you can see Massachusetts, New Hampshire, and Vermont, where they're reaching kind of double-digit uptake in lung cancer screening. But there is one other area that gives me a tremendous source of pride, and that is in Kentucky. The only state outside of the Northeast to be shown to be among the leaders. We're actually number 3 in terms of uptake of lung cancer screening. And it's not just due to the volume of eligible individuals because of tobacco use histories. It's actually corrected for that in terms of leveraging the percentage of individuals who are already eligible, nudging up above 10% into the top 3 category. You know, no one's happy with 10%, but it's a far sight better than the data from Nevada, where only less than 1% of individuals have been shown to be screened for lung cancer, even though they're eligible for it. And how have we achieved this in Kentucky? Well, I believe it's because of adopting a socio-ecological model to understanding the implementation of lung cancer screening, from raising community level awareness all the way through instituting monitoring and feedback mechanisms to help our lung cancer screening programs, but fundamentally working to take a person-centered approach to really keep the participant at the center of the process as much as possible, and to do things in a community engaged manner that helps rally support and understanding as opposed to more program or system-based efforts. Going the wrong direction. And I mentioned before that we've adopted the socio-ecological model of lung cancer screening and created and adapted it to try to understand, you know, what we can do and at what levels of the issue are we working. And the ones I'm going to talk about mostly today are things that work at the screening candidate level, but also that work at the community level. And I will touch on some healthcare system, or rather lung cancer screening program operations as well. In the process of thinking about these individuals, putting them at the center of this process, you'll see that we have a very unique community that we're trying to serve. And the first part is this is a stigmatized community. Individuals who are not necessarily embraced by the healthcare community, but they also experience a sense of self-blame for having such a substantial tobacco use history. This is also a fatalistic community. I mentioned earlier that many people in Kentucky know at least one family member who has died of lung cancer, and they know what a lung cancer death looks like. They don't think that there's much that can be done about it once it's diagnosed. In many ways, people believe that that is their natural trajectory and cause of death in the future. It's also a somewhat skeptical and lower socioeconomic resource community. And so when we message and market with these fancy new tools, many times that's interpreted as, hey, that's not for me, or wow, that hospital really thinks I'm stupid enough to give them all my money in order to get that scan so they can be rich and I can find out that I have a disease. It just doesn't make sense to me. They're benefiting more than I am. is also disengaged with community of individuals, that's not monitoring for new activities or new health opportunities to improve their well-being. So we have unique challenges in reaching them with regard to their health communications and messaging. And finally, they're quite dispersed. A higher percentage of individuals live in rural areas where they don't have tremendous access to resources, or at least convenient access to resources, and programs available to them might not have the multidisciplinary team that's available at an urban academic medical center or a large healthcare facility. And so thinking about this community in these ways, not to stereotype, but actually to work with these, to leverage our communications and strategies to support them, to understand the value of lung cancer screening, is one of the strategies that we have taken to help our programs implement lung cancer screening. My colleague, Dr. Lisa Carter-Harris, spent some time at Indiana University working with a community. And Indiana has very high rates of tobacco use, particularly in the southern Indiana area that borders Kentucky. And she did some really strong qualitative work initially looking at the stigma that's faced by these individuals in terms of their screening decision making, the distrust that they feel among this community. Like I mentioned earlier, that there were folks that think this is just a money-making scam, like a bait and switch. They just want us in our system. And to be honest with you, I've been in meetings where a hospital administration kind of present this argument that they stand to make a lot of money off of individuals who are diagnosed with lung cancer through a lung cancer screening program. And so in some ways, they're not very far off in terms of some of the boardroom level discussions about implementing lung cancer screening. But fundamentally, the other thing is that these individuals, I believe, have shown a defensive information processing style. So we can't just put up billboards and things like that and just expect them to naturally follow through. If we do it in the wrong way, with the wrong words, the wrong imagery, they're very likely to turn away from that and disengage from it, as opposed to actually move forward with a process where they might end up having a low-dose CT scan. My colleague Margaret Byrne and I have been collaborating for nearly 20 years now on looking at various aspects of lung cancer screening. And if you calculate that, that was way back before there was actually data to support it. But what we were seeing in those early 2000s was that lung cancer screening was available on a non-data driven basis, but by individual radiology practices. And so we went and surveyed those folks who were participating in these programs, despite the lack of data or policy to support them. These people, we found, were very satisfied with their experience. They were also motivated to participate in lung cancer screening because they thought it was helpful, and it was simple, quick, and painless. And so there was no downside to their experience, and that they were completely unaware of the potential harms associated with low-dose CT, of which there are substantial harms possible in terms of a combination of false positives, radiation exposure, et cetera. But the most interesting thing that we found out about interviewing and talking with these folks is that the vast majority had never consulted a healthcare clinician prior to going to lung cancer screening, and most of them had not talked with a family member. And that really gives you the sense of how isolated these individuals feel in terms of this decision-making process. And so a natural solution to that was to generate some decision tools to help support people's process of making choices about lung cancer screening. When we started this process, we actually thought that we were developing a tool that would help people kind of understand why lung cancer screening might not be a good idea for them. But eventually, of course, the data emerged as to, under certain protocols, that it could actually be very beneficial. But we did some decision-making research using a strategy called conjoint analysis, where people are asked to weigh different aspects of a choice against each other and make real-life decisions about participating in screening. And this data draws on 5 parameters that we thought would be related to decision decision-making about lung cancer screening. And as you can see here, the factors that weighed most, whether someone went forward or wanted to proceed with lung cancer screening or not, were weighted by the healthcare clinician recommendation, which makes sense. That is traditionally the biggest influential factor and why I've described them as the ignition switch to the lung cancer screening environment, but also the out-of-pocket costs. Once again, very basic understanding. And the third most important factor was access to screening. Now, most interestingly, people that understand the benefit, the lung cancer screening, the scientists of screening really get into this parameter in terms of the benefit being mortality reduction and the primary harm that's considered from lung cancer screening, the false positive rate, which can lead to additional testing and perhaps even invasive procedures as a major problem. These were the two least influential factors in terms of decision making, and it was more these logistical and contextual factors that were really driving those decisions. However, when we also took a look at this tool, this conjoint strategy as a possible intervention approach, when you're presenting the actual information about the decision to folks, and many of them had never heard any of this before, so we asked them, we administered a survey called the Decisional Conflict Scale, which essentially measures someone's uncertainty or angst about making a healthcare choice. But after going through the actual conjoint procedure, you can see that people felt much more confident and much more clear in what kind of a decision they would make, whether they would pursue screening or not. They felt like their uncertainty was dramatically reduced. And in these cases, the decisional conflict is higher is worse and lower is better, indicating more clarity. You can see better clarity and perceive that their decision had more support otherwise. So we took the next step to use this conjoint evaluation strategy to develop a decision tool with some funding from NCI. So we built Lucas Choices on the backbone of this model that were desired to help people have accurate information, to empower them with the skills to talk about their healthcare clinician about a lung cancer screening choice, and then also put it in the context of what they believe is important, what their healthcare goals are, what their personal values are, and how they think about lung cancer screening in general. And we did this by sharing information about the background of lung cancer screening and the data, as well as their eligibility. We use question prompt lists that some folks are aware of to generate questions that they could ask a clinician that they weren't clear on, and help support their skill development to be an active participant in shared decision making. And then for the values clarification, that is where we included the conjoint valuation exercise and the feedback to individuals. This is what our decision aid looks like at its structure. You can see across the top border of knowledge, empowerment, values. We also included some additional resources and some background information about our team. I don't have enough time to show details about this, so I'm going to jump to just showing you the preliminary results that we found when we did our feasibility and acceptability trial. Bottom line is that we compared it against the NCI lung cancer screening website and found that both interventions were highly feasible and generated optimism for pursuing this. That there was a lot of user satisfaction, but it did not differ between Lucas Choices and the NCI website. There were also many other non-differences in terms of usability, acceptability, and feasibility, but there were a couple of signals where individuals felt more confident in going a little bit deeper with Lucas Choices because of the exploration process, and felt more engaged with the decision than if they just read a flat decision or a flat informational website. And so we've used this feedback to create Lucas Choices 2.0, and we've received some favorable grant score, but we're resubmitting in the future to move that forward. In a bigger scale, that sort of highlights one of the efforts that we've taken to help support individuals in considering the lung cancer screening process. But the other part of this equation is the lung cancer screening program and how they help facilitate lung cancer screening. And this is kind of the rational model of lung cancer screening that many screening programs ascribe to. You go out there, you identify your high-risk candidates, you screen, you identify nodules, you do the follow-up, you diagnose lung cancer early, you treat it early, and you reduce reduce lung cancer mortality. And in a just and rational world, that makes sense. But in reality, the process tends to go a lot more like this, and that it's a lot more complicated. And particularly one of the aspects is working with this community that's very new to the screening environment. And this is where we come back to defining high quality lung cancer screening as fundamentally person-centered and community engaged. And our work has been to build the tools and supports to make that happen. I want to go back to making the point about the community awareness campaign. Roughly what percentage of adults know what a mammogram is and who is eligible by just visualizing this machine? I want to point out that it's nearly 100% of adults who understand what a mammogram is, and yet 50% will never, ever have one. However, what if we were to show someone what this is and describe that this is what is used for an LDCT scan? You know, we're essentially at 0% public understanding of what lung cancer screening is, and until we can get to that community-wide understanding where lung cancer screening is becoming more normative, more accepted, more socially supported, we will never achieve the rates of uptake and adherence that are being experienced in mammography. To achieve that community level awareness of lung cancer screening, we worked with the Kentucky Lung Cancer Network, which is part of our Kentucky Cancer Consortium. In the early 2000 teens, we recognized that lung cancer was starting to transform. The death and destruction and the fatalism and the stigma that had been pervasive was giving way to some new research, some new opportunities. And so we formed a group of people that was very interested from across the state in leveraging these new opportunities. And it included community leaders, healthcare professionals, as well as advocates and policymakers to try to do what we could do to leverage these new and exciting opportunities and become an organizing force for that. One of the things that we did was to create the Great Kentucky Lung Cancer Screening Roadshow. And Evelyn, we have some community outreach coming for you, so thought I'd highlight that there. We have the benefit in Kentucky of having what are called district cancer councils. And these are in 14 different regions of Kentucky that bring together and have annual meetings that talk about specific topics with regard to the latest and greatest things that could impact Kentucky's cancer burden. You know, recently they've had district cancer council meetings on vaping and some other issues. But this year, or the year 2013, 2014, they decided to focus on lung cancer screening at our encouragement. And these brought together these different organizations, communities, advocates, and clinicians for a bi-directional sharing of cancer-related concerns, perspectives, and importantly, bringing the data. So we started to do these, and after the publication of the National Lung Screening Trial and the draft guidelines for the Preventive Services Task Force. And really what we did is we put forth a structure where a regional cancer control specialist who was well known to the community organized a local primary care clinician, a local lung cancer screening expert, sort of a statewide or national expert, and then a state cancer prevention control leader who would come in and talk about some of the lung cancer data burden and on there from an epidemiologic perspective. And so what we were trying to do here was to communicate to the community about the burden, but also the opportunity. So we would talk about the challenge, but also give them this, the potential solution in order to create a relevance and draw people into this topic as a way to achieve, community engagement, not with us, but with this topic to start to change how our Kentucky society would view lung cancer. And that our goal was here to reinforce implementation and uptake of lung cancer screening. And having been here in Colorado now for, going on 11 to 12 months, we were sort of doing our own version of the boot camp translation work that's so popular here in terms of working with the community. And in this case, I realized boot camp is typically used with clinicians, but we were engaging clinicians as well as community members in the process of engaging them in decision making and determining what is right for their communities. So, the roadshow had direct and indirect benefits, because every time we went to a community, we talked directly with people, but they would also have media coverage for us to talk to them, and to the TV, the radio, the newspaper would all there and do interviews to try to spread the word. We found tremendous engagement, a lot of interest in screening among clinicians and community. And partly is this because you can't be a clinician in Kentucky and not have a fundamental understanding of the toll of lung cancer in the community. Even among pediatricians are very clearly aware of the burden of lung cancer in Kentucky. But yet there were still significant pockets of apprehension, concern, skepticism, and frank stigma. These people don't deserve it. They did this to themselves. Why are we bothering to screen them? That kind of thing. Even among clinicians, showing a misunderstanding of the equation and some concerns about giving people access to this new technology. And that we really recognized, despite the enthusiasm that grew out of this, that there would be a lot more work that would be needed. And so from that, we developed a continuing education program that targeted primary care clinicians based on what we learned out of these district cancer councils. And with this grand round style presentation, we were with the goal of trying to help people learn about the lung cancer screening fundamentals, to give them the information, accurate information that would help them populate their shared decision-making consultations with the individuals at risk, and that helpfully developed a multidisciplinary environment to facilitate collaboration. And here's the segments or the content that we were doing. Essentially, the first half focused on the lung cancer screening to give people that information that would populate their shared decision-making consultations. But then the latter half was on the shared decision-making, developing those skills in terms of, and talking about navigation, cessation, shared decision-making in the context of lung cancer screening. Our early data from this intervention showed that we were, wildly successful among primary care clinicians at improving their knowledge of lung cancer screening, and statistically and clinically improving their level of self-efficacy, confidence, and comfort in doing this. However, I want to highlight that this is still on a 1 to 5 scale, and we only got them to the middle. I mean, this is dramatic increase, but still, this isn't even among the lung cancer community of clinicians who are saying, well, yeah, this is important, and I think we're helping, but we've got ways to go yet. And so we developed another intervention to continue that discussion with our clinicians. And we were fortunate to compete for funding from the Bristol Myers Squibb Foundation to do this program project style grant that focused on provider education, survivorship care, as well as working with lung cancer screening programs to promote prevention and early detection. The provider education efforts were focused largely on academic detailing, where folks, trained individuals from our groups and with the partnership of the Kentucky Cancer Program, would go into primary care settings with tools and education platform with regard to lung cancer screening. And well, actually, it was not lung cancer screening only, it was more comprehensive lung cancer prevention and control. But most of the tools were about lung cancer screening in terms of advertising and decision aids and things of that nature. And this is hard work. This is primary care is busy, complicated place with not a lot of time. And sometimes you would only get 5 minutes to go and make your spiel and leave your goods with them. But we took every 5-minute segment we got. And sometimes they would say, yeah, we'd love to have you give the hour-long presentation. And we would go in there and do that and follow up with them. So we did combine whatever amount of, we fit whatever time they would give us and packed it in with the tools that we could give them in that time space. But much of it was just opening that conversation and getting in the door and raising awareness. They would also have access to other online training courses and webinars over the course of time. This is one of the most amazing things that I think, that we successfully reached almost over 1,400 primary care clinicians in Kentucky, as well as over almost 1,300 non-primary care clinicians who were educated, reaching, thousands of individuals who are interacting with patients eligible for lung cancer screening and raising their awareness, providing tools of this new opportunity, and really transforming the perspective of the clinical community with regard to lung cancer screening. The other angle of this is you can't just rev people up for lung cancer screening and not have access to high quality services. So one of the things we did was also working with lung cancer screening programs to make sure that they had the tools that they needed to be able to support efforts for high quality lung cancer screening. And this was also part of the Kentucky Leads Collaborative. So what we did was used implementation strategies, primarily the audit and feedback support tools that we paired with a quality implementation evaluation strategy, and then the study resource portal that we had that offered continuing education as well as resources that they could adapt to implement in their program. You can see that there was continuing education for virtually every member of the screening program team, but also different tools in terms of to help people develop or plan programs, manage programs, operate programs, and as well as a range of patient education materials that they could rebrand and use independently. Following the publication of the NLST and guideline support, Peter Mazzone and colleagues associated with the American College of Chest Physicians and American Thoracic Society started to think about quality. And they put together this 9-parameter quality document that identified what the essential core quality parameters should be. Now, the nice thing is that this was a nice footprint or blueprint for moving forward. But the challenges of this was that it was a groupthink kind of a process. And you had folks that weren't that supportive of integrating smoking cessation, some that were really advocates. But the best that they could do is that they needed to have some smoking cessation activities involved within a lung cancer screening program. So that leaves the door open to handing somebody a pamphlet and saying, good luck, Joe. You can quit using this pamphlet. And obviously for this community of individuals, that's not a very high yield rate in terms of likelihood of helping them achieve success. So while smoking cessation is technically a quality parameter for lung cancer screening, it doesn't mean that folks are really doing it right or leveraging that opportunity as effectively as possible. So we thought we needed to adapt this and developed our own system called QUILS, which is Quality Implementation of Lung Cancer Screening, with our cute fuzzy little guy as our mascot there. And we had these 6 parameters, but we went beyond the technical aspects of lung cancer screening to include some of those things like community outreach and engagement. Primary care simply doesn't have enough time in the day to focus so much effort on lung cancer screening, and their relative yield is small. However, for a lung cancer screening program, it's how they see the world, it's how they interact. So putting the responsibility for community outreach on a screening program makes a whole lot more sense because it has more direct benefit to them, and to encourage them to do responsible marketing and outreach, as well as not just to the community, but also to their provider community, their clinical community, to help educate them about the benefits, harms, and procedures associated with their program. And you can see some of the other areas. The other thing that we did with this is we put numbers on these. So we quantified the quality parameters so that we could score programs, give them feedback, and then pair that up with the tools that we had provided in order to help them improve the quality of their program. And that's what we've been doing with the QUILS index for the last couple of years in Kentucky. So some basic principles. We know QUILS index 1.0 is wrong. Like any model would start out, it's going to take some iteration. And so we've created bidirectional communication relationships with our sites to help improve QUILS over time and to promote achievable and valuable metrics that show the utility of thinking about quality. And so here's a process. We assess the quality at baseline, we give them the feedback and present it in a report, but then we pair that with access to this resource portal that specifically maps onto the tools that they need to improve their program. And then we go back to them after a period of 6 months and evaluate them again and see where things have changed and what haven't. Has not changed. And we did this several times. So in our first phase, we did the site visit, we gave them access to the intervention, and then we went back and gave them another round of feedback. This time we provided a stronger encouragement to access these tools and a better map to get them to the places they need to go. But then after this year, we kind of go dark. We drew access to see if they could sustain the quality over time. And that's where we are are with most of our programs, we're in this final phase. And you can see we're pretty well represented across the entire state of Kentucky, or the Commonwealth of Kentucky rather. And many of these are more rural programs. We see many of them in far eastern Appalachian Kentucky, addressing the burden there, but also all the way out. Interestingly, the Paducah site is a program that's been running for some time because of the environmental and occupational exposures that have been in the Paducah community, as well as Owensboro was a satellite site for the National Lung Screening Trial. So it's not like none of these programs don't have some level of experience. And like I said before, this is a little bit newer data showing that Kentucky, once again, is still among that top tier of implementation of lung cancer screening. And let's face it, if anybody spent any time in Kentucky, other than Raj at the distilleries, that there are not many parameters where Kentucky is at the top for a good reason on anything related to health. And yet lung cancer screening is one where we're actually leading the country. We're also put together an approach in collaboration with colleagues at the Moffitt Cancer Center and the Longevity Foundation of an overall broader approach to implementing lung cancer screening called the Engaged Approach, built on that person-centered and community-engaged process. And that we think that treating every candidate or participant contact or communication as a precious opportunity to build engagement and facilitate adherence to the lung cancer screening algorithm. That we train all the lung cancer screening program members to message engagement and adherence in their interactions with participants. In particular, we have helped them with this mnemonic of the 5 E's for all patient encounters. And we're helping encourage them to engage, to empathize with these individuals, to educate them about the screening process, to empower them to ask questions and to go deeper and to make a stronger commitment. And then we always encourage them to come back. The last word that they should hear in the lung cancer screening process is, Jamie, we look forward to seeing you next year, to set that expectation that they come back year after year. We also really appreciate the importance of navigators and identifying a single point of contact, trusted contact for programs to reach out and connect with, or for individuals to reach out and connect with, so they know who they're talking to from the very beginning through their entire experience. And of course, we're also very invested in engaging referral sources and other community-based efforts to spread the word about the opportunity to participate in and be supportive of lung cancer screening, and to create that societal norm that this is a good health opportunity for folks. So to summarize sort of my perspectives on implementation of lung cancer screening, it's been cautious. The uptake has not been great, but there have been very specific strategies that we've employed to really facilitate the screening in Kentucky. We think that future benefits would accrue from really focusing on more multi-level strategies. There's no magic bullet here. Even if we get primary care completely on board, that there's still other ways to fall through the cracks on this process. That we really have to continue to develop a thorough understanding of this focus on the target community and the challenges and barriers they face to engaging the lung cancer screening opportunity. That understanding these in the context of implementation science frameworks and principles, from a scientific perspective, really gives us the best chance to move this field forward. And finally, that one of the things about the lung cancer screening community is that there is a recognition that, it's kind of pessimistic to say, but it's also kind of optimistic to say that, hopefully we will never do lung cancer screening as poorly as we did it yesterday. There's so much information coming out about lung cancer screening, and we're learning new strategies ways to support individuals and move this process forward. And we need to be engaged with each other and sharing and persisting in efforts to support this. So I have just a few minutes to talk about the lung cancer survivorship work that we're doing. And I wanted to highlight why focus on lung cancer survivors. One, it's a community that experiences tremendous burden, and it's an opportunity for innovation and impact of our work. And frankly, one of my motivations is stubbornness. And that is born of this particular slide right here. This is the first funded research project I was ever involved with as an assistant professor back at the University of Louisville School School of Medicine and the Brown Cancer Center. My colleague and I received funding to do what would have been incredibly innovative intervention at this time. We were doing a comparative effectiveness trial before comparative effectiveness was a term. We were going to compare supportive expressive therapy, which is an evidence-based approach for survivorship, against a mindfulness-based stress reduction approach. And we thought doing this in lung cancer would be terrific. Unfortunately, from the screen, you can see the white and red bars are our projected accrual for this trial, and the lower bars there was our actual accrual. So over the course of the year, you can see that people pretty clearly gave us the signal that that they weren't interested in what we had to offer, and that we did not do this in a sufficiently person-centered, patient-centered, community-engaged strategy. But rather than giving up, that experience kind of stuck with me, and that's why I became somewhat stubborn in continuing to think about how we need to do this better to meet the needs of individuals diagnosed with lung cancer. And we came upon a precision approach where instead of, we don't have a biomarker to test to determine whether someone needs a survivorship intervention, but we do have preferences, patient preferences, what they see, what individuals see as their essential challenges, their values, their beliefs, and their opinions about what is going to improve their cancer experience. And so we developed a precision medicine approach to survivorship that targeted the unique challenges that individuals, but it was tailored to what they were experiencing and what they would accept in terms of an intervention. And it's all built on a partnering and supportive style of interacting with individuals rather than an educational approach. And there was a shared decision-making element too, where we would give people a menu of opportunities of topics that we would address, and they would choose from that. And we implement this at 10 sites with the goal of 300 participants in this trial that combined symptom coping strategies, basic lung cancer information, caregiver support, as well as addressing psychosocial concerns such as distress and well-being. We also, importantly, because we were designing for dissemination from the very beginning, we included a training program that was transportable and easily adopted that included extensive online training. We didn't require an oncology social worker or a psychologist to deliver this intervention. We required whoever the site said was their cancer survivorship point person. So whoever it was, sometimes it was a nurse, sometimes it was a psychologist, sometimes it was a social worker, and in one case, it was a lay navigator who was that person, and we wanted to provide them with the tools. This is one of my favorite slides because I actually, instead of signaling the significant differences, the red and yellow bars are the non-significant differences. Basically, we were able to train folks across all these different topic areas, and there was statistically significant improvement in their confidence to address these concerns with lung cancer survivors. And bottom line is that you can see here our accrual rate was dramatically different than in the other trial. And I think signaling that we still didn't meet our full accrual, but we were cramped due to a variety of other parameters, and we were testing sites. And so this was merely one of our hypotheses with regard to feasibility, and we met most of our feasibility and acceptability parameters. We ultimately accrued over 214 individuals into this trial in just a little bit over 18 months. Period of time. And here's one example with one of our sites, King's Daughters in Ashland, Kentucky, then went above and beyond. And over the course of their expected accrual, they actually contributed 49 survivors to our actual participation accrual. And so I think, even though I haven't presented a lot of data on the survivorship piece, there's a lot of encouragement about the acceptability and I think the feasibility as well. And that this is actually one of the projects that we submitted for a grant, and we're waiting to hear about the notice of award to continue this work in rural settings. But I'd be remiss if I didn't at least conclude with the emphasis on a little bit of acknowledgement of the burden of stigma, that there's so much wonderful innovation happening at every level of lung cancer prevention control. And stigma is the dark cloud that halts or impairs our ability to really leverage all of these new innovations. And we want to make sure that it is our job to get those out into the community. That to conclude, the data is strong. There's tremendous amount of promise that's out there for for lung cancer screening, and our challenge is implementation. We want to support our communities and to see this high-risk community of individuals truly benefit. And the window is quality. The window is through implementation science, things that are person-centered and community engaged, that fit within the context of these individuals' lives and in order to achieve that well-being. And I'll stop there. And I realize I'm totally right at the time, but I'd be happy to hang out for a few minutes if people want to ask some questions, pose some challenges, or just if you need to go, I totally understand. So thanks for your time. Thanks, Raj. Thanks, Evelyn. I see that. Does anybody have any
I have a quick question, Jamie. So I have been referred several times in this talk related to bourbon. Where can I get a good bourbon here?
There's a bar in where is it? Gosh, I don't know where it is, but it's a Kentucky themed bar, and they have quite a variety of bourbons available there. I'll get it. I'll get the name of that for you. But otherwise, you should probably head to Kentucky again when the pandemic relents and get your fill there. I mean, I think that's the only reason Raj wanted me to come here, was that he knew I'd be his connection to Kentucky bourbons.
Thank you.
Mm-hmm. Any other comments or questions from anyone? Laura, you have any thoughts about the decision-making work?
Hey. No, I was actually thinking about how to work in, of course, getting back to the stuff that we talked about together quite a bit, how you're thinking about preference sensitivity now, and an incorporation of personalized risk estimates.
I think it's going to be a really important opportunity to integrate precision screening and with the inclusion of personalized medicine. And I've even come more to that conclusion since you submitted your application and thinking about this. I was exchanging some email with Carmen as well, because one of the things we fundamentally don't communicate to individuals is, obviously the harms of any kind of screening, but also the fact that the benefits and harms vary across the trajectory. One person does not have the same probabilities of benefiting and experiencing harms as the next person based on their risk and their commitment. And so, but yet we communicate in a way with folks that's rather standardized, and yet we really know that that's not the case. And so, but then again, I think we gravitate to the least common, the simplest approach to communicating with folks, and it doesn't necessarily end up being the most effective in the long run. And it's the same way with how we communicate at lung cancer screening. The shortcut is to tell people to do it. The problem is that doesn't really generate a lot of engagement or motivation to come back. The hard way is to engage them in the decision-making process where they fully commit and understand the importance of long-term commitment to the screening algorithm. But that's hard, and folks don't want to do it, particularly where folks have negative feelings toward this particular community. They're even less likely to exert the additional level of effort to achieve some of these outcomes. And so they back off and they just don't implement lung cancer screening at all. It's amazing. One of the pieces of data that we collect from our sites is who refers to the programs for lung cancer screening. We have some clinicians that referred over 100 individuals in the space of a year to a specific screening program out of family practice or pulmonology or something. And the partner in that group that sees the exact same population had referred 4. And so you see this tremendous amount of variability between clinicians and their engagement with lung cancer screening, where if two groups of practitioners, clinicians. We're seeing the same group of women who are eligible for lung cancer, for breast cancer screening. I really don't believe you'd see that amazing differentiation or variability. I mean, of course there's variability, but not 100 versus 4 when you're in the same pool and population of individuals. Well, I can close off there and give everyone the rest of their afternoon back. But thanks for letting me spout off for an hour, and I look forward to working with everyone going forward.
Thank you, Jamie, for doing it.
Thanks, Raj. Appreciate it.
Yeah.
Bye, everyone.
Bye.